Okay, well, thank you again. And I just want to say that it's a great honor to be introduced by the president of this Congress. So thank you very much, Dr. Stefano De Podomo. And I want to thank the organizers for progressing this symposium by Kedron, and I want to recognize the huge efforts made by the company and by Rinque. Now I have some new friends in Uruguay, and I want to thank very much Gustavo Adamo and his team for organizing this seminar under somewhat difficult circumstances. So I think that should be recognized. And I also want to thank Anna Choplin for similar efforts. You've already seen this. 25 years ago, this would have been probably not a very important subject, although in hemophilia, inhibitors have always been recognized as being a very important safety issue. Up till about 25 years ago, our biggest priority in terms of safety in this field was to ensure the development of pathogen safety as a way to remove the threat of infection which devastated our community in the 70s to the early 1990s. This is a fight which is now, I would never say over, but which we now have at the moment think we have won. There have been no infections from plasma-derived products treating hemophilia for at least 25 years for any viruses, and it is quite important to realize that the opposite to what was the situation 30 years ago, the products of mainstream blood transfusion, such as red cells, plasma, and platelets, today are less safe than the products used to treat hemophilia, because with the products used to treat hemophilia, we have introduced inactivation methods which are very efficient, which are still not available in the mainstream transfusion products. I wanted to emphasize this fact because this now has allowed us to focus our attention on the very important problem of inhibitors. And inhibitors are recognized now as the biggest single problem, and this is not a trivial issue. Not a trivial issue. You will observe from this slide, which shows from the INSIGHT, so-called INSIGHT cohort, which are European and a few Australian centers, that inhibitors have a significant effect on mortality in the patients where they arise, compared to inhibitor-negative patients with hemophilia. We have a high level of mortality, and much of this mortality is hemophilia related. In other words, these patients are bleeding to death. So this is a problem, and this is shown as well in the CDC data from the United States, and you can see here that there is a significant level of mortality related to inhibitors compared to without inhibitors in regards to bleeding type problems. No longer do we see these problems in regards to HIV and so on, but we are seeing this huge problem with bleeding. So this is not a trivial issue. It is not so dramatic in the public mind, and in many of our community, the memory of the devastation of the viral infections with AIDS and HIV and with hepatitis C and the other viruses is still fresh enough to make people perhaps underestimate the magnitude of the inhibitor problem, but this is a huge problem. So I am going to develop over a fairly long talk some basic concepts on how we think inhibitors arise in hemophilia, what we can do about it, and then I will attempt to develop the relationship between the type of product possibly and the incidence of inhibitors, and discuss in the end a very important recent randomized clinical trial. First of all, you have to understand that antibodies to factor VIII are actually, if I may call it, a natural phenomenon. And this is fairly old data which shows that if you do the Bethesda assay on normal blood donors, you will get a reaction, you will get a positive titer, a low on the whole positive titer, in a somewhat less than 20% of the donors. And this can also be shown that you can purify anti-factor VIII immunoglobulin from these normal individuals. So, normal people without hemophilia also get antibodies to factor VIII. But when you look at these antibodies to factor VIII, you will see that the titer, as I showed on the previous slide, in normal individuals is very low. In severe hemophilia without inhibitor, the titer is again low. Very few of them have a titer of 1/80. But in the people who have inhibitor, whether it is from congenital or acquired hemophilia, we see a high prevalence of high titer inhibitors. Practically all of them have high titer. Why do inhibitors occur? Well, I think myself, not being an immunologist and being fairly, naive to this kind of concept, my question has always been why inhibitors do not occur. Because if you are not having factor VIII, I guess you should recognize factor VIII always as a foreign substance which you raise inhibitors. But it is more complex than that. And this is a cartonic representation from one of the best immunologists working in this field, Dr. Lacroix Desarmes from Paris, and basically shows us what we think happens in relation to the generation of inhibitors. So this first part is effectively also going to happen in some normal individuals, that you get factor VIII being recognized by the antigen-presenting cell, being presented to T cells, proliferation of T cells, generation of plasma and B cells, and the generation of neutralizing antibodies. So we have a situation whereby this process is amplified, if you like, through aspects, through characteristics which are found in some patients with hemophilia, but not all. And our efforts are always to try to find out which are these factors. We can classify the factors in two general types, what we might call external or bystander type factors, including stimuli to the immune system, which include surgery, infection, vaccination, and so on. And also the important, very, very important aspect of genetic predisposition. In other words, are you born, apart from being born with hemophilia, are you also born with the predisposition to generate inhibitors? In this talk, I will concentrate on inhibitors to factor VIII. We can, if we have time, say something about factor IX in the discussion. Now, this is a comprehensive summation of what I have just said. This shows the risk factors for inhibitor development, and we can classify these in terms of the patient's own environment regarding challenge to the immune system through immunization, infection, surgery, etc., through genetics in terms of the actual factor VIII mutations, through the polymorphisms in the immunoregulatory genes. We know that family history in inhibitors is very important. If you have a family history, you have a big chance. African Americans, this is actually still a controversial subject, but most publications agree that African Americans have a higher incidence of inhibitors. And of recently increasing importance, the question of whether the type of treatment, the type of factor VIII, the regimen of factor VIII, the level of exposure is actually also important. If we look at the role of factor VIII gene mutation, this is a meta-analysis which was published some years ago, and in this meta-analysis they took as the reference point, where the odds ratio is 0, the most common mutation in hemophilia, which is the intron 22 inversion, which I'm sure you all know about. And then they looked at the literature in regards to the inhibitor incidence relative to other mutations, And they could classify in a rather interesting and elegant way relatively low risk inhibitors, and as you go further down here, the risk decreases and the odds ratio shifts further to the left, and high incidence inhibitors, particularly large deletions, multiple exon and single exon mutations, nonsense mutations, and so on. So the first point is this, because you are going to hear a lot from me regarding the effect of product. The effect of product is important, but most important is the patient. It's always the patient which is most important, and the type of inhibitor which comes about from the patient's mutation. Of course, if the patient has already got a predisposition genetically to inhibitor, then we need to understand the other factors, including the external treatment-related factors, intensity, surgery, vaccination, and so on, and the type of product in order not to increase the genetic predisposition and the possibility of getting an inhibitor. So let me say something first about what I might call the external risk factors. And this is from a series of data from a very nice paper in Seminars on Thrombosis and Hemostasis just a couple of years ago. Peak moment at first exposure day overall doesn't seem to be very important. Of course, like everything else in medicine and science, there is discussion and controversy. This is the data here. Peak moment at any exposure day, roughly the same. Overall, towards a higher odds ratio, but not very big. Surgery at first exposure in some key studies is shown to be important. Surgery at any exposure is shown to be less of a likelihood. Remember, ladies and gentlemen, whenever you see these bars, these error bars, transcending downwards, it means there's great variability. The frequency of factor VIII exposure, again, if it's high, seems to indicate a higher level of inhibitor risk. These are all very important trials published over relatively the last few years, including the big study, Rodin, which you are familiar with, involving pediatric patients, the Canal study, which kind of preceded it from the same group, the group of Stephanie Go in the Netherlands, and so on. If we look at dosage, again, intermediate versus high, seems that we get somewhat of a higher. Very importantly, in my mind, and here we start entering the problem of pharmacoeconomics, i.e. money, you can see that prophylaxis, apart from all its benefit in preserving joints and so on, prophylaxis seems in many studies to give us a lower chance of getting an inhibitor. And this is, I think, quite an important finding, and this is, again, from the Rodin group, who show that after 20 exposure days, and I am presuming that you know very well more than me what we mean by exposure days, that we get a very interesting decrease in prophylaxis relative to on-demand, and this is, I think, quite important. So, that is something about the external factors and the treatment factors, and we will come again later on to the question of the type of product. But let's talk a bit now about the treatment goals for patients with inhibitors. The first goal is in relation to the treatment of acute bleeds, and here we have bypassing agents. This is, remember, treatment, okay? Then, as is the case with patients who do not have inhibitors, we enter into the discussion on prophylaxis in order to prevent bleeds. Prophylaxis with the bypassing agents. I will talk about this. Most important of all is the question of the eradication of the inhibitor, to remove it, to remove this huge burden on the patient and this huge burden on the health system. Tomorrow I will talk about the economics, the pharmacoeconomics of aspects of hemophilia, particularly about inhibitor. But a patient with inhibitor can cripple the budget of a standard hemophilia center, especially in countries where resources are not as plentiful as the privileged countries in which I have lived. So we need to somehow or other eradicate the inhibitor. To eradicate, as I shall show tomorrow, is very beneficial. However, it is very expensive. Most patients with hemophilia A successfully eradicate with a good ITI protocol. Interestingly, the success rate is much less with hemophilia B. Okay. So let's talk about the bypassing agents, whether they are used in treatment or in prophylaxis. We have at the moment two types of bypassing agents. One is the traditional activated prothrombin complex, APPC, PCC products derived from plasma, which have been used now for about close to 40 years. The other type is the famous and extremely expensive recombinant factor 7A product, of which at the moment, in terms of global availability, there is only one product, although there are other products restricted to certain markets. For example, in Russia, they have their own recombinant 7A. It's not Novo Nordisk's product. It doesn't cost its weight in gold, and it works very well. And you can see here the composition. So basically, these APPCs work through having a number of activated and non-activated coagulation factors. They target the prothrombin X complex. They have a half-life which is 4 to 7 hours. This is the dosage. 7A works through activating factor 10 on activated platelets. It has a much shorter half-life. This is of substantial importance in terms of improving the use of this agent. And these are the dosages. So we've got these two types of inhibitors. Well, which is the better? This is one of the key questions. Let me tell you, these are both expensive drugs. Depending on the market, depending where they're trying to sell them, these are extremely expensive drugs. It is the case that generally, not always, generally, recombinant 7A in the open market tends to be more expensive. So the question of which works best is a relatively important one. And of course, this has been addressed through a study, and this is the famous PHENOX study, which compared FABA, which is practically the only activated protein C, it's not the only activated prothrombin complex concentrate available these days, and Novo7. And the conclusion of the study, which you can see here, is that they appeared to have a similar effect on joint bleeds, although there was a difference observed by a substantial proportion of patients. In other words, overall, they seemed to be equal in efficacy, but some patients seemed to do better with APPCC, and some patients seem to do better with Novo7. And this, I think, and I look to the treaters in this audience, of which there are several, is the general experience, that it is indeed the case that for reasons which we don't fully understand, some patients with inhibitors appear to respond better with one product versus the other. Overall, in this substantial trial, they seemed to be reasonably similar. But I think this teaches us the lesson that we must always center our attention on the patient. These overall trials, these big trials with substantial number of patients deriving from them statistical outcomes, are useful indicators, but they don't tell us much about the individual patient. Tomorrow I will talk a lot about the personalization of treatment, especially relative to the new agents which are available, and we can develop this idea further. Okay. Prophylaxis. Like the situation in hemophilia without inhibitor, prophylaxis overall is of substantial benefit to people who have inhibitor and are treated, I emphasize the word treated, with the agents. In other words, these people are not tolerized, that they have the inhibitor. And you can see here from this study, which had quite elegant data, the difference between bleeding events for people who are on demand and on prophylaxis, according to the treatment sequence, and whether these bleeding events were joint bleeds. Every time, prophylaxis wins. That's the first point. The second point, which is not so evident in this data, is that even with prophylaxis, we get substantially larger numbers of bleeding events in inhibitor patients than we get with prophylaxis on non-inhibitor patients. I come back, therefore, to the first problem. And therefore, given that it's a well-known maxim of public health and medicine that hopefully prevention is better than cure, we would like to, rather than have to treat or prevent these inhibitors, we would like to get rid of them altogether. And the way to do this, so far, is through immune tolerance induction. And you know, basically, the principle is to expose the patient, as a result of complex protocols, to increasingly massive doses of factor VIII. And as I showed before, around 80% of the patients overall with hemophilia A will respond by gradually, and this can take more than a year, and consume massive amounts of factor VIII. This will gradually remove the inhibitor to levels which are therapeutically not important. These are the relevant protocols, and I'm sure that you know about all these, and I refer you to the original literature in relation to the exact protocols. They all work through the basic replacement with massive amounts of factor VIII. The Malmo protocol, which has been around for many years now, also utilizes immunosuppression and a column to remove the factor VIII through immunoaffinity chromatography. Some years ago, Dr. Hay, Charlie Hay, and Donna Di Michele published the results of the very big inhibitor ITI study in blood. This is a key study in our understanding on inhibitors. And they managed to find a lot of information through studying a lot of patients and the protocol where in relation to the variables which give us success in immune tolerance induction. It's obviously very important to understand these variables. One of them is, for example, whether you use low dose or high dose. Given the enormous expense of the treatment in terms of the factor VIII, this is obviously very important. They found that actually both doses gave a similar success rate. In their study, it's a bit less than the overall experience, it's about 70%. The high-dose regime did give a shorter medium time to get a negative titer, to get a normal recovery, but to get to tolerance itself, to the removal of the inhibitor, it was basically the same. This is also from the ITI study, and it shows you those factors which were good predictors of success to the protocol for ITI which was used by Charlie Hay and Donna Di Michele. And you can see here that the peak historical inhibitor titer, the peak titer on ITI, and the peak titer in relation on ITI of 250 versus more than 250 Bethesda units were significant predictors of success. None of these other variables observed in this study showed any relationship to the possibility of inhibition induction tolerance therapy being successful. This is the Italian study. This is the PROPHET study from the Italian centers, ably led by my good friend Antonio Coppola in Naples. Another very big study, as big as the ITI study. And here you can see that in this study, the predictors of success were, again, as with the ITI study, the historical peak titer, the titer at the start of the protocol, and the inhibitor peak on ITI, whether this was less than 100 Bethesdas per mil. These all showed, because in green, significant good predictors of success, relationships with success. All these other things, nothing. I draw your attention, because it is my aim to be totally objective, I draw your attention that in this series, the type of concentrate, whether it was a factor VIII von Willebrand, factor plasma-derived product or a recombinant product did not create a significant difference in terms of the success of tolerization. We will discuss this further later on. Coming again to the profit study, you can see here the same type of data we showed in that meta-analysis, but to a specific cohort, the Italian cohort, that you had mutations which were more or less of a lower risk down here, and mutations which were more or less of a higher risk down here. And these are fairly similar to the kind of data which I showed you on the earlier meta-analysis, so that substantial mutations like large deletions and translocations and nonsense mutations are much higher in terms of the risk than these relatively small mutations here. Now I want to start progressing my remarks towards the question, therefore, of having looked at the genetic type predisposing factors and having looked at the external factors involved in treatment, such as whether you're doing surgery, etc. Is the actual type of product which you administer of importance? First of all, I would like to say that in relation to this issue, most of the studies about inhibitors have come from previously untreated patients, from what we call PUPs, babies or young children, exposed over the first year or so of their lives until a certain level of exposure base gives them an inhibitor. These are the pivotal studies. We have also got a number of retrospective or prospective studies conducted in one or other centers. And these have used different types of products, whether recombinant or plasma-derived. We've also had prospective cohorts of newly diagnosed pups with severe hemophilia. In other words, these are patients, as soon as they're born, they start being observed in a prospective cohort. It's not a retrospective analysis, and it starts as soon as they are diagnosed. We also have now, around the world, several excellent safety databases. This is the UHAS database maintained in the European Union, administered by Michael Makris in London. And this has really, its major raison d'etre, its major reason for existence is to assess, detect, and understand the question of inhibitor resistance in treatment. And just this year, this is going to be the focus of the last part of my talk, we have had one randomized clinical trial. Think about that. In the world of evidence-based medicine, everything happens in relation to randomized clinical trials. And I personally am interested to discuss the, if you like, the pros and the cons of having randomized clinical trials. I think they have a role. Sometimes it's good, sometimes it's not so good. But just think that in hemophilia, we have hardly any randomized clinical trials. So now, as I shall show you, we have a randomized clinical trial to assess the question of whether product from plasma or recombinant influences inhibitors in the form of this study. And I'll come back to that in a second. But the reason why I bring this up is that the most controversial risk factor for the development of inhibitors in hemophilia depends on the type of product used, whether it's plasma or recombinant. This question has occupied our minds now for 20 years or even more. The moment products started, before the recombinant products, you remember we had products which were very highly purified. They were pure factor VIII. They were purified from plasma using monoclonal antibody columns. They had no von Willebrand factor. And as soon as these products started to appear on the market, there started to become a discussion on whether these products without von Willebrand factor had a higher incidence of inhibitors. It looked like was the case. But remember, none of this was clinical trial, none of this was evidence-based medicine. It was all just retrospective or prospective cohort reports. So let us now discuss the question in a bit more detail. Plasma-derived products, as you know, and this was also shown by Anna shortly, very impurity and the factor VIII and the von Willebrand factor concentrate. Recombinant products, which are produced until recently all in mammalian tissue culture, are of very high purity. They do not contain von Willebrand factor. I would like to say that, just in case that anybody thinks I'm advocating for any kind of product, I am a strong believer that all these types of products are desperately needed for the well-being of the community of people with hemophilia. And I have to say, as someone strongly associated with the plasma industry, that the plasma industry cannot make enough factor VIII for all the people with hemophilia in the world from the current plasma supply available. We need the recombinant products. It is absolutely unimaginable that the population of people with hemophilia in China and India, once their governments decide to allow these people to live, is going to be able to be treated purely on plasma factor VIII. There's just too many hemophilia people there. So I emphasize, don't think that I am pushing one side or the other. Both are needed. Why do we think, though, that the presence of von Willebrand factor may have some relationship to the immunogenic potential of factor VIII? Well, we have the amount of von Willebrand factor, and this concentrates the physical state and structural change of factor VIII and the affinity of factor VIII for phospholipids. And then we have the question of post-translational modifications. As I was saying, when I was showing you in relation at least to von Willebrand factor, the production in the cell of origin, we have glycosylation. Glycosylation is important. When we have glycosylation, that depends very much on the type of cell in which it is made. If the molecule is synthesized in a human cell, it will have a glycosylation pattern which is different than if the product was to be synthesized in a different type of cell, like a mammalian cell, a rodent cell, like is used for the recombinant factors. And also there are other aspects, like for example sulfation. If you look at, for example, the recombinant factor IX benefics, it has a lower recovery than the plasma-derived factor VIII because translational modifications do not happen in the cell line where it is used. So these things are extremely important. They affect the characteristics of the molecule. Now, if we focus again on von Willebrand factor and factor VIII immunogenicity, under normal conditions, von Willebrand factor binds to the treatment different epitopes. In addition, it can have an immunomodulatory effect and is able to block antigen presentation of factor VIII by dendritic cells. I showed you this when I described for you why von Willebrand factor is needed in the circulation to keep factor VIII stable. So we think that it has an interaction with the immune system. And if we go back to our slide from Professor Lacroix-Demas, you can see that if we have von Willebrand factor, we can block the interaction of the factor VIII with the antigen-presenting cell, which ultimately generates the inhibitors. This is shown in this nice slide, which looks at immunofluorescence in order to see the reduction of endocytosis of factor VIII by dendritic cells. And basically, when you have the factor VIII with von Willebrand factor, there are not so many immunofluorescent cells, which shows that not so much factor VIII has been eaten by these cells, whereas if you had only factor VIII with serum albumin, the situation is obviously very different, and the factor VIII has been absorbed by the cells. Is there an influence on the development of anti-factor VIII inhibitors and PAPs? I'm going to show you quite a lot of data. Here is a series of analysis, meta-analysis, and some of it not meta-analysis, involving many studies. The first one, which was shown many years ago, is the one by Wright and Paisley, and although they published their work initially in 2003, White and Paisley's analysis keeps being updated, and in fact this is a very recent update with studies much, much after 2003. And you can see that when we look at the median inhibitor incidence between those studies which use plasma-derived, those studies which use recombinant, we have approximately half of these studies, half of the incidence of inhibitors in the plasma-derived. It's not always the same. Look at the outliers on the plasma-derived group and look at the outliers on the inhibitor, on the recombinant group. But overall, this is what we observe. Recently, we've had a very interesting observation in the Rodin study. It was published in the New England Journal of Medicine. Nobody had the faintest idea that this study was on the way, because the Rodin study had already been, we thought, fully published, and this important observation was not there. But of course, the authors kept the best till last. And in this study, the second generation full-length recombinant factor VIII of one manufacturer showed a higher incidence of inhibitor. Overall, there was no difference. Observe that overall, there was no difference. But this study looked at different types of recombinant factor VIII and plasma-derived factor VIII and found that the so-called generation full-length factor VIII showed a higher incidence of inhibitor. I don't think I'm doing anything wrong if I say that this actual product is the product which was known as cogenate SF. Following that observation, 3 cohorts, including the original, observed the same thing. So that along with the Rodin cohort, we had the cohort from the French Haemophilia Treatment Network, France Coag Network, and the cohort from the United Kingdom. And all of these looked at the risk factors which I have discussed before, the high-risk mutation, age, exposure, peak moment, and so on, which may or may not be linked to inhibitor. They were shown to be comparable, and they showed that, as with the Rodin, if you use the full-length factor VIII of another manufacturer, use Advait as the reference, the cogenate FS always had higher inhibitor incidence. It seems, therefore, that this was a real observation. And this is showing us the progression of inhibitor incidence. You have seen this type of slide before, relative to exposure days for the different products. And this is the cogenate SF compared to Advait, compared to the French Factain, plasma-derived. And you can see that the inhibitor incidence is higher in the Advait and highest of all in the cogenate FS product. But both recombinants are higher than this factor VIII von Willebrand containing plasma-derived. The EMA, the European Medicines Agency, and this was reported last month at the Orlando meeting of the World Federation of Haemophilia, not last month, in July, has analyzed these data, and basically, since I noticed that I'm running short of time, I'll just impart that they confirm the observation of the individual investigators, and so we must wait to see what will happen as a consequence of these actions, of these observations. But let's now come back to the previously unexposed patients. So I reiterate, this is showing again in a bit more colorful way what we saw before, that we have many studies which indicate that in the recombinant we have a higher incidence of inhibitors, but all of these are cohort studies. They're all observational, they're all retro or prospective, some very good prospective data, and none of this is the result of a randomized clinical trial. This is a very nice meta-analysis by someone who I have a great regard for. I think he's one of the cleverest people in hemophilia, my friend Alfonso Iorio, who is Italian but works in Canada, and he did a meta-analysis. And basically, he showed that there was no statistically significant difference. I emphasize statistically significant difference. This is a meta-analysis. This is statistics. This is arithmetic. Okay? However, observe that in his study, in his meta-analysis, again, recombinant was higher. Not statistically significant, but higher. And this is, again, a similar one, which shows basically the same thing. So we always end up with a difference. We always end up with the, more or less, with the recombinant being higher, but we never get to statistical significance. What does this mean? This means that we are uncertain. This means that the opinion is not yet conclusive. And this is the basic condition for what we call equipoise in medicine. What we call equipoise is the basis of evidence-based medicine. That you do a clinical trial when you are uncertain, when you are genuinely not sure what is the therapeutic answer to your question. Well, we were not sure. There were indications, but it was necessary, in order to answer the question, to do, if possible, a randomized clinical trial. About 8 years ago, Alessandro Gringeri, a very eminent haemophilia clinician in Italy who now works for the industry, he works for Baxter. At that time, he was still working in Milan with his very distinguished colleagues, Piero Manucci and Flora Pevandi and Elenia Sant'Agostino. And 9 years ago, they published the intention and the design of a clinical trial to answer the question which I have been talking to you about. And they called this the CPET study. Survey of Inhibitors in Plasma Product Exposed Toddlers. It's actually not a good title because this wasn't a survey, this was a randomized clinical trial. Okay. Does it working? Sorry, but I'm not getting a response. Can I get the slide moved? Let's go.
Por favor, si puede cambiar la diapositiva o arreglar el sistema de presentación, por favor.
Ah, but this is, okay, Avanti. Okay. All right, so what is the treatment design? This is a head-to-head study between two classes of products. Okay? The investigators had the assumption that in terms of the plasma-derived products, they needed to put into the study products which also had von Willebrand factor. Not ultra-pure, high-purity plasma-derived factor VIII like the monoclonally treated products, because of the thinking about the effect of von Willebrand factor on the immunogenicity of factor VIII. So they compared two classes of products. The class of plasma-derived factor VIII products containing von Willebrand factor. And they actually had three companies, Grifols, who produced two of these products, Alphanate and Fandi, Kedrion, Hemoclot, and Factain, which is produced by the French company LFB. And they compared these products to the class of products of recombinant which were available at the time. You will observe that none of these products are the new generation of so-called longer-acting recombinant factors, which I will talk about tomorrow. So this is what they compared. The data indicates that the biggest contributor to this trial was actually the product Hemoclot, which is manufactured in Italy by Kedrion, and these others were 50-50 between themselves. So they compared these products. You can read the paper in the New England Journal of Medicine, and I apologize for the slide, but it is simply the illustration of the randomization. Okay, so you don't have to really fully understand that, just take it from me that the randomization was successful. They managed to randomize. Here are the key data from the CPET study as published in May. It was first reported late last year at ASH, and in May it was published in the New England Journal. And you can see that basically we do get an effect, and there is a difference between the two arms, the plasma-derived and the recombinant factor VIII. This difference is both for all inhibitors and high-titer inhibitors. Some important observations. The difference between the two arms for all inhibitors, including the low-titer, okay, was not just below statistical significance. It was not fully significant for all inhibitors. For high-titer inhibitors, it was. Okay. Now, there were a lot of potential confounders in this study. For example, this study drew from a large number of countries. There were a lot of patients. I know that the Pegron product was used in about 80 patients in India, patients in Egypt, some patients in the Western world, a lot of patients in Iran and in Turkey. And so, was there something related, perhaps, to the country? Well, you know, a lot of people talk a lot in relation to the study about Caucasian and not Caucasian, and I think that this is nonsense and quite frankly verging on the racist. When you say hemophilia people in this country are, you know, more likely than in another country, we know that this is not the case. It depends on the mutations. But the long and the short of it is that when they looked for the effect of the country, there was no effect at all. So this was not the problem. And they looked at many other types of variables which could have affected the result. None of them really had an effect. This is the paper. Patients treated, therefore, with plasma-derived factor VIII containing the von Willebrand factor had a lower incidence than those treated with recombinant factor VIII. Now, this is an important study. What do we have here? We have here the demonstration. Remember, these were pups that, in these patients, if you give over the first 50 exposure days, it's actually more likely to be just the first 20 exposure days. But if you give over the first 50 exposure days, plasma-derived, there is a lower risk of inhibitor than if you give recombinant. After that, there's no change. Okay, after that, they're no longer pups, they're now PTPs, previously treated patients. The whole question with previously treated patients is a different question. So the situation is we wait until 50 days. If at 50 days there is no inhibitor, they're not going to get an inhibitor. But in those 50 days, the chances of this baby or this young child, because these are previously unexposed patients, they're previously untreated, actually because they were in India and so on, some of them were not so young, yeah? Because some of them were teenagers, because they don't get treated in India anyway. Okay, as was said by Anita. Okay, so in the first 50 exposure days, if you treat with plasma-derived, you have a lower inhibitor incidence. It is quite substantial. The patients on plasma-derived overall got 26% incidence. The patients with recombinant got 43%. That is huge. Another important observation is that this is the first study, this is the first clinical trial, but even comparing it to the surveys, to the cohorts like Rodin and Canal, the incidence of inhibitor in the plasma-derived group is quite high. It is quite high. This problem is huge. This is really a very big problem, and people need to understand that this needs to be very strongly addressed, and anything we can do, we need to do in relation to pressing down. Yes, lots of. I can see the thing here. So, what do we conclude? Now we have the European Medicines Agency. It is reviewing the situation. We will see what they do. There is also the question of how to tolerize, whether the concentrate, if it has von Willebrand factor, can tolerize the patient better than if it has not. This is a nice piece of data from Johannes Oldenburg in Bonn, who believes very strongly that this is the case. He believes very strongly that to tolerize, he has to use plasma-derived with von Willebrand factor. This is shown with this study, where you can see that changing the concentrate from the recombinant to a von Willebrand plasma-derived removes the inhibitor. However, if we look at a meta-analysis, just take the conclusion from this, the meta-analysis indicates that this is not the case. So the question is still open. So I want to come now to some final reflections. I never put conclusions at the end of my talks, because there are never conclusions. You never finish. You never stop learning. I emphasize again that inhibitors present a very serious challenge and an increased mortality and morbidity in a high proportion of patients. At best, a quarter of pups get inhibitors. This is very serious. The treatment agents are quite good. The bypassing agents are good. Prophylactic regimes are better than on demand, as always. But the best thing is to introduce immune tolerance induction. This, as I said, is very expensive. Tomorrow I will talk about that aspect more. Certain products have been apparently associated with higher inhibitor rates. In my mind, there is little doubt that the observation regarding cogenitive fest is a real one. It has been produced by very credible investigators and very solid data from good surveys, and I think that the use of this product in pups needs to be done with great reservations. And remember that these clinical decisions need to be done against a background of information. And if you have a patient who has been born in a family with a high probability of inhibitor, who has a large deletion mutation in factor VIII, it would be clinically foolish to increase the risk by giving a product which appears to increase. This is an example of being cautious. We now have had the first randomized trial addressing this issue, the secret study, and I salute the people who carried out the study and the patients involved. This indicates that plasma-derived concentrates carry a lower inhibitor risk than recombinant products in pups. Remember, the difference is 43% versus 26%. And therefore, pending more studies, and we never stop doing studies, prudence and individualized therapy should be followed, and patients at high intrinsic risk may be treated with plasma-derived product at least until the first 50 exposure days. And in terms of the world, this is not a bad option, because these are small babies, and we can produce, the industry can easily produce enough plasma-derived for the small babies. We cannot produce, because there just isn't enough plasma. There are not enough donors in the world for all the patients, especially as they are growing older and needing more on the basis of body weight. But for the small babies, we can, for the first 50 exposure days, produce enough plasma-derived. If I were a treater, which I must confess I am not, I would adopt the practice that, based on the individualized patient characteristics, especially if there is a high background risk of inhibitors, then at first the child should be exposed to plasma-derived, given that these products are safe. The decision can then be reviewed after 50 days, especially as the child grows older and needs more product, and perhaps at that time recombinant can be reconsidered. However, as I've said, and this is my key message to you in this talk, that irrespective of the source, do not focus too much on the source. The risk is high. It comes mostly from the background of the patients themselves, and we need to address this through innovative therapies. And tomorrow, I will say something about innovative therapies. The cost of treating and the cost of ITI is also high, but tomorrow I will show you that it's actually